Hello, I am so thrilled to be here with Dr. Tom Roesler, Professor Emeritus at the University of Washington Medical School in the Division of Child Psychiatry. Prior, Dr. Roesler was on the faculty of Brown University for 17 years, where he founded and directed the Hasbro Partial Hospital Program. This program provides intense family-based treatment for children with complex medical and psychiatric conditions. Dr. Roesler is also co-author with Dr. Carol Jenny of the book Medical Child Abuse Beyond Munchausen Syndrome by Proxy. So Dr. Roesler, hello, thank you again. How would you like to begin this discussion?
Well, I can begin by thanking you for inviting me. This is really a great opportunity. I'm realizing that we're taping this, and other people have spoken before this tape gets played at the meeting, and I'm a little conscious about maybe repeating things that other people have said. People might want to give me a little bit of leeway if I say things that have already been said. But I like to begin these kinds of talks by giving a definition of medical child abuse. It's a child receiving unnecessary and harmful or potentially harmful medical care at the instigation of a caretaker. And it's a bad thing that happens in the life of a child. This is a point I like to make to keep everybody kind of aware that what we're dealing with is child maltreatment. We have physical abuse, sexual abuse, emotional abuse, and medical abuse. They have many features in common with one another. They all involve a child being harmed. They can all present with multiple kinds of presentations. There are different, in specific ways, medical child abuse is specifically identified by the medical community being involved in the harm that's caused. One feature I like to emphasize is that, like other forms of child abuse, medical child abuse exists on a continuum from mild to moderate to severe. And we often think more about the severe cases, but I want to have people continue to think that we're going to be seeing many, many more mild cases than we do severe cases. And the pediatric community, the child abuse community, needs to be ready and aware. You mentioned that I was the director of the Hasbro Partial Program. We saw the program's been in effect now for 25 years. It's treated about 5,000 families. And a small percentage of those actually had medical child abuse, maybe 5%. But even 5% of 5,000 is a lot of kids. And we were able to see kids all the way across the spectrum. So I think that gives me a special perspective that others might not have who only get involved in the various serious cases.
Well, and Dr. Roesler, one of the when you talk about your features, your particular emphasis that many of us don't have is treatment. You're not to make a plug for your program, but to make a plug for your program, you have all of that experience. So tell us a little bit about the management or treatment, which often eludes us.
I will, and I'll start by saying that I've come to believe that treatment of child abuse in general happens in 5 steps. The first step is to identify the abuse is taking place. We can't have any treatment unless we identify that a child is being harmed. The second step is to stop it. If we have identified abuse, we're ethically, legally, morally obliged to attempt to stop the abuse. The third step is to provide for ongoing safety. It's not okay just to stop the abuse if it starts again in a month. So we need to provide for ongoing safety. Step 4 is to deal with uh, the emotional and physical consequences of the abuse to bring the child who's been harmed back to a normal functioning state. And the 5th and the most difficult, and this is where the concern becomes apparent for everyone. We want to do this by preserving the integrity of the family as much as we can. We want to be able to maintain the family unit the child comes from if we can guarantee that that child is going to be safe when they are sent back to that family. So this is a sophisticated audience we're talking to here, and we have lots of experience of people identifying child abuse, stopping child abuse. It's the getting the child back into the family in a constructive way, and in a way that we can really have some assurances that the child is not going to be harmed. That's going to be the tricky part.
Great. And so you brought up a very important point that I should have pointed out in my last question. So you are a psychiatrist. Many of the people on the call are not, and they are doing, which I think is especially the first number of steps, not the last one, but leading up to the last one, are all things that the general pediatrician or general practitioner or child abuse pediatrician can do in terms of treatment. The last one, it sounds like, is really the alleged perpetrator, sort of, and the family system itself. So I want to break those out a little bit. Talk at first for people, those first number of steps that you can take, what people on this call need to know, or on this webinar need to know. And then the second part is one that for all of us who would not be treating the perpetrator, sort of, so sort of have you talk about both of those in turn, what the treatment looks like for the alleged perpetrator and for the family.
Yes. Successful treatment, in my mind, is being able to follow those 4 steps and then get to number 5 and have the child be reintegrated into the family. That's not always possible. And we'll be talking specifically about things like informing sessions, which people are probably familiar with as a test to see whether or not a child can be reintegrated. And I consider it successful if we can stop the abuse and if we can make that child safe. And if that means that the perpetrator is never able to psychologically come to terms with what she's done to the child, but we can still keep the child safe, I consider that a successful treatment. That doesn't mean that we wouldn't want to understand the perpetrator. I'm very comfortable saying that the motivation of the perpetrator of medical child abuse is just as important as knowing the motivation of the perpetrator of any other kind of abuse. We need to know why the person did what they did. Why did a man beat up his child? Was he drunk? Was he psychotic? Did he think he was providing an important lesson to the child? The why is always important when you start thinking about, can I send that child home? And so people have spent 40 years trying to figure out the motivation of a mother, primarily a mother, getting medical care for a child they don't need. And we've come to understand that there are lots of different motivations. There's many ways that people can come to this point. But if we're going to send the child home, we better find out what that is. And so this is the time when you want to get that psychological evaluation. And you want to see if the mother is anxious. Is she able to work with the medical care community, or does she have a belief system that is just so fixed and rigid that putting a child in the hands of that person is not going to be safe. So successful treatment is keeping the child safe. That's the my fallback position consistently.
And all right, you opened the door, so I will walk through it. You did
Okay.
say mother. And people, so I don't think that we've heard yet today on this webinar much about the perpetrator. And again, through your unique treatment program, you have probably had more experience and sort of more time with these mothers than anybody else. So let's talk a bit about, before we talk about, even more about treatment, about the perpetrator, characteristics of the perpetrator, and just your experience.
My experience is that there are as many different reasons for people doing what they do as there are situations. Remember, if we have mild, moderate, and severe cases along a continuum, we're going to find people who are misusing the medical care system in lots of different ways and for lots of different reasons. And it's just important to find out where they are. In our treatment program, we emphasize that we have to start where the family is. We have to find out, we have to immerse ourselves in the family's reality and find out what they're thinking, how they got to that way of thinking, before we can introduce new ways of thinking. We have to understand what we're dealing with. And the easiest way to conceptualize this is that it's really important to listen to not just the mother's view, but the other family members' view, the grandmother's view, the kids' view, and then compare that with what we think might be helpful for the family moving forward.
And this isn't a question, but I do want to clarify something and tell me if you agree or not. We were just using the word perpetrator or alleged perpetrator, and I was going with your sort of language of what we're talking about here is child abuse, just like any other form of child abuse, physical abuse, sexual abuse, neglect. And so we would think of that as a crime, perhaps. But when we're talking about what we're talking about, though, one thing you mentioned at the beginning is there is a continuum. So when you're talking about the mild side, we may not call that medical child abuse at that point.
Right.
If it's an anxious mother that maybe just needs some extra time with the pediatrician or extra reassurance from the medical provider. So just to sort of make that point clear, do you agree with what I just said?
I do agree. And like with other forms of abuse along that continuum, there's a line. And when you cross the line, and the line differs, it differs in different cultures at different times. There are still cultures around the world where hitting a child with a stick is perfectly normal child rearing behavior. It doesn't cross the line in that culture, but in our culture, in America, that would cross the line. Where's the line when somebody is using the medical care system to get harmful medical care? It's kind of, you know it when you get there. And it's not a decision that doctors can necessarily make without bringing in, and here's where we start talking about the team. Here's where we start talking about having help, getting help. Many of people in this audience have been parts of multidisciplinary teams, and you know the power of having multiple points of view. But in particular, it's saying, when is enough enough? When have we crossed the line? The Hasbro Partial program that I was part of was fortunate in having a continuous involvement of a number of people for many years. We worked really well together, and we worked really hard to maintain this cohesive group of this cohesive team that could take a new situation and bring it into an understandable framework. Not everybody has that, and we'll talk some more about what you can do if we haven't already talked about it at this meeting.
Right, and then just another point to just highlight, we have previously heard from somebody, you are US based, we previously heard from somebody in a different part of the world, and we know that we have so many people listening, which we're so grateful for, but we know that all systems are different. And so again, you are US based, that is your practice, that is your knowledge. And so the things that you're saying in terms of reporting are things that are sort of based in statute and culture in the United States. So just again, just to clarify that. So
And different environments are going to have different
exactly, and
understandings.
we all know that even within your own country, even within your own region, that the way that
Yes.
The way that we practice can be different, or the response from other professionals can be different. And so we've talked a little bit about sort of what successful treatment will look like. One of the things that you also write about in your book, and that's a practice at Hasbro, is contracting with families. And I think that's such an important point, because that doesn't have to be in a special program like yours. A special treatment program, that can be a contract between a provider and a family, or teams in the hospital and a family. So I think that's a very broad, sort of very broad thing that many people can use, and I think it's so important. So can you teach us a little bit about that?
Sure. This actually evolved as we worked with families and came to the understanding that our way of looking at using the medical care system might be at significant variance from the family's way of looking at the use of the medical system. And when we thought that we really are going to have a demarcation, an end to the old way of looking at things, and a beginning of a new way of looking at medical care delivery, it evolved out of the informing session, which I think many of your people probably know about. It's been written about by various people, including us. And that's where you sit down with the family after doing a thorough evaluation, and you inform them that you have good news. Their child is not sick. Your child does not have a seizure disorder. It does not have mitochondrial disease, does not have intractable asthma. In fact, your child is pretty healthy, might have a little bit of allergy, but he or she's doing fine. Isn't that great news? And the response to the informing session is a diagnostic test. If the response, and this has happened many times in our program, we've had families say, "Oh, thank goodness, I'm so happy to hear that my daughter is healthy." We've had people actually say that. We've also had people say, "You're crazy. I'm going to take my child to Mayo. They'll find out." The Mayo Clinic in America. So it's a diagnostic test. But in addition to that test, we have come to use what we call a contract, a medical care contract. One piece of paper where we write down all of the illnesses that have been ruled out and the illnesses that still exist. And we get every specialist involved in the care to sign the contract. And then we offer to get the parents to sign the contract. So this is a black and white stepping off place for the new way to get medical care be different from the old way. The contract says your child is well, and we want you from now on to only get treatment in this particular way. Will you sign the contract? If they sign the contract, then we put it in the medical record. We send it down to the emergency room. We send a copy to every medical care provider so that the entire medical system impinging on this child will have an understanding that things are different now. We're not going to do things the old way, and the parents have at least signed this contract saying that they're going to do it in the new way. And I think this is something, as you say, Kathy, this is something that people can use. The power of it comes from the family understanding that the entire medical community agrees. And we're going to get to that, how difficult that is in a minute. If you see a piece of paper and there are 5 doctors who've signed it, we all agree, it makes it more difficult for somebody to maintain a belief system against all of that evidence. So we use these contracts fairly frequently. In Seattle, where I'm based currently, we see do about one evaluation a month, 12 a year for medical child abuse. And frequently, we end up having contract sessions with these families.
Right, and I think it's just such a powerful tool. The contract, it tells, allows both the family and all providers, when you put it in the medical record, which it should go there. It just gives, sort of all of the information right there. And we know that families sometimes go to other institutions, whether it's in the same area, different countries, they will travel to other areas. So it does give a big piece of information. So we have a few minutes left. I don't want to end on this, so I may cut you off.
Okay.
Because I want to end on something more positive, but we know this is hard. This is a really hard diagnosis. It's really hard treatment. So tell us some of the biggest obstacles to successful treatment.
Number one, getting all the doctors to agree. Doctors have strong opinions about things, and if they have been treating a patient in one particular way and someone comes in and says, I think we should look at this differently, they sometimes have a hard time getting on board. And it's obvious that if there's one doctor, even one doctor, who says, oh, I don't agree, who's the family going to listen to? Who's the mother going to listen to? They're going to go to that. They're going to go to that one doctor. So that's the first obstacle. The second obstacle that we continue to run into is getting beyond our own medical care system and involving social services, because social services in areas just have no experience with what we're talking about. They might send out an investigator to talk to the mother, and gee, she sounds so reasonable and she works so hard to take care of her child, and I don't see any problem here, doctor. What's the problem? The same applies to judges. We have judges who we can present evidence and they don't get it. Our response to this, by the way, is to not just make a telephone report to social services. We make a written report saying specifically what happened to the child and what the mother did to get that to happen to the child. We don't use words like Munchausen syndrome by proxy. We don't say mother's crazy. We say this is what happened to the child and the child needs protection. And it has the more concrete your letter can be, the better you're going to be able to get, better response you're going to get from social services and the legal system. So those are the things I think that that we're still struggling with. My final point, I guess we're getting to that point, Kathy.
We are, I was going to say, we have probably less than a minute left, so give us all your wisdom. And
Well, my wisdom is that wherever you are, be prepared for the next case that's going to come in. Don't wait until something happens and then say, what do I do now? What do I do? I better go read Dr. Roesler's book. No, be ready before the next case comes in. Talk to the people in social services. Have your pediatric community forewarned that it's going to happen again. We're going to have another case come in where it just doesn't make any sense, and we're all going to be feeling really bad that we gave care we didn't need. And so be ready for the next one. That's my my take-home message.
that is a beautiful way to end education. We're all educators, and you're here. People are here on this webinar because they want to learn more. And we do need to educate everybody around us. So, Dr. Roesler, thank you so much for talking with me and sharing 25 minutes of your knowledge. I know we could have gone on for hours and hours, but people on this webinar are very lucky because you're going to see Dr. Roesler live in a minute, and you will be able, along with our entire panel of speakers, be able to put in the chat some questions, and we will hopefully get to all of the answers. So Dr. Roesler, again, thank you so much for your time.
It's been a pleasure.
The pleasure was mine. All of ours, actually.